Hello, I'm Phil Goropoulos, President of CHI St. Joseph Children's Health. Thank you for joining us through our second installment of our conversations about healthy communities. Throughout our history at St. Joseph Children's Health, we've been committed to listening to our communities, listening to our leaders, listening to our hearts, and following God's path for us as we try to create a healthier community here in the Lancaster region. Part of that challenge is first defining what a healthy community is, exploring what that possibility might look like, and how we create this world and community in which all of us have an opportunity to be successful and thrive. For today's conversation, we're being joined by Sister Mary Haddad. She's joining us from the Catholic Health Association, where she is currently serving as the President and Chief Executive Officer. For the past 11 years, roughly, she's been at CHA, working in various capacities, but prior to that, worked as both an educator and a social worker prior to joining the healthcare world, not just in the United States, but really in countries throughout the world. So we're really honored to have Sister Mary join us. So thank you for joining us today from Catholic Health Association.
Thank you so much for the invitation, Phil. It's a pleasure to be here with all of you.
We'll kind of launch right into it with a question really kind of about the purpose of Catholic healthcare. So, there are many Catholic hospitals across the United States. We obviously work for a Catholic health system here at CHI, St. Joseph Children's Health, as part of Common Spirit Health. And I believe something that really sets Catholic healthcare apart from our peers in the field, both other religious systems as well as secular organizations working in healthcare, our systems and our concept of Catholic healthcare is longstanding commitment to the health and welfare of our communities as a whole. So not just about our patients in our patient rooms and our exam rooms, but outside the walls of our hospitals and our acute care and outpatient centers. That it really calls us to go beyond and begin to nurture and create healthier communities in those areas in which we are working. What I found interesting is when I joined Catholic Health Initiatives in 2014, is I learned this wonderful thing about us creating healthier communities. And I would say to my boss and to our colleagues, well, what does it mean to have a healthier community? Like, what are we trying to create? Always trying to say like, okay, well, what are the things that are evolving and what should we be making sure are pillars within our community? And I always got the answer that, well, it depends, it's a local option. So I wonder if from your experience, if you could describe the essential characteristics and traits that you would attribute to a healthier community?
Sure. I think to look at it, and this is also from the Catholic lens as well, as we talk about what Catholic social teaching has taught us. But when I think about community or healthy communities, I think about all those social conditions that contribute to the life of an individual and also to the human flourishing of that person. So, the things that we think of are most basic to us, safe and affordable housing, clean water, healthy food, access to education, an income, a basic income level, or some sort of employment that allows a person to have a living wage. Those are all aspects of that allows us to be healthy and allows us to function in our communities in a way that we can then contribute to the community. I think it's important to recognize that it's just not about the individual, but it's about the individual's contribution to the life of the whole community. So that notion of communitarian theology that we know within Catholic healthcare is so important to us as well. So those are the, I would say, more or less some of the basic things. I would also say safe neighborhoods, that we're able to be in an environment where we feel somewhat, protective and able to live our lives without any of the external pressures and stressors that are put upon people who live in areas of high crime and high violence.
I think one of the, there are so many key points in there, I think really align with our philosophy and our approach here in Lancaster. One of the things that I found interesting, and we've found interesting as we continue to explore our role in the community, is that concept of the common good. And the idea that we're not just in it for ourselves, but we're in it for the collective, like that we all advance by advancing together. And I wonder your thoughts, both as an educator and as a social worker. I've found that that's challenging, and even in the context of today's world with the pandemic and the politicization of wearing masks and the idea that my individual freedoms to not wear a mask somehow supersede your right to have your health. How do we go about recapturing that sense that the common good has equal and even sometimes greater value than an individual or an individual right?
Yeah, it's very challenging, I think, in our country because we have seen how polarized we are. And certainly the simple thing is mask wearing has elevated that to, this level of polarization. I have to say, just to give a little plug for the Catholic Health Association, we put out a campaign to encourage mask wearing called Love Thy Neighbor. That it really isn't about protecting me, it's about protecting the other person. And it is what, we want to do because we recognize that all my actions and what I do has a direct impact on another. And so how can we be more mindful of that in how we live our lives, I think is very important. Phil, I have my little iPad in front of me because I wanted to read this to you. And it's something that I stumbled upon a number of years ago when I was doing some work about community health and the recognition of looking at the common good. And it is a definition of Aboriginal health. It's from Australia. And it says Aboriginal health means not just physical well-being of an individual, but it refers to the social, emotional, and cultural well-being of the whole community, in which each individual is able to achieve their full potential as a human being, thereby bringing about the total well-being of their community. Mm-hmm. So that notion of the common good, if I'm able to be healthy, it's going to impact the life and the good of the whole community. And, I was just so attracted to that definition because they're so explicit of talking about common good. Mm-hmm. I think in our country, we have a hard time of doing it. Years ago when I went for my MSW and I was actually wanting to do an international practicum. And it was actually at a Jesuit, St. Louis University, and the priest who ran the program at the time, and he said, why do you want to go do this program abroad? I know you've done some volunteer work in Belize and you've done some experiences there. You've already had your third world experience, in other words, right? And I said, no, I want to learn how developing countries really structure those social service programs, mm-hmm. and how it looks in a different, more of a communitarian country than a very individualistic country as in the United States. So I learned a great deal there, and I learned the importance of, and you've said in our pre-conversation before we started recording, the importance of listening. The program that I work with in Trinidad, it's still in existence, had started back in the 70s, and it is throughout the Caribbean. And the priest who started it said he took 3 years before he did anything in the community he was trying to serve. And he said, we have to rid ourselves of our own cultural arrogance to think just because I have a certain degree or I came from a certain location, I know what this community needs. People know what they need. They just don't have access to the resources to get that. So we have to listen and keep listening in order to be able to open ourselves to respond and help the community get to what they need. So it was a great learning for me, and it helped ground me in the work that I do, even in healthcare and to this day. Mm-hmm. So I think you're right. That notion of common good is a hard sell sometimes because we've been so socialized in an individualistic culture.
It's an interesting approach to it when we talk about listening, and it's one of the things that I talk about with our providers here. So we have a behavioral health program with psychiatrists and therapists on, and I always am coming back to them not as a clinician. I don't pretend to be a doctor nor want to be, but what did your family, the family you're working with, what did they say their goal is out of this? Rather than approaching it from I'm going to fix you or I have the answers, but how do you jointly find a path to be on together? We always talk about at the basis of our ministry is the Road to Emmaus story, which so many people are, might have heard, but aren't really that familiar with. And I was like, it's about being on a path together. It's not about showing or being the leader. It's about walking hand in hand on this journey. And how do we create that environment? And I think sometimes in healthcare, we buy into that complex that we have the answer, because maybe we understand the science or the medicine behind it. And I always try to remind my team that it's an art, but it's not an art by ourselves. It's more like dance, where we're in partnership with our patient, and you've got to find the right step, and it's a step together. And I wonder if within this environment, in terms of the current structures of our healthcare system, where there's such a premium on time and billing and fees and seeing as many patients as possible, how we reintroduce the concept of medicine as a relationship that does foster not just the health of our patient, but a larger kind of blossoming of health within that family and the circles, the concentric circles that person also creates in the community. I imagine that ties into some of the work that CHA has been doing around the idea of kind of restructuring the way we envision healthcare in this country, both with the Affordable Care Act work that was done when you guys were such a key voice in getting that passed. And then today, when we're still saying there's so much work that could be done to truly give us spectacular healthcare, and that the Catholic health systems should be at the forefront of that. So it seemed like more of a statement, but maybe you can comment to that.
Well, I think bottom line, the importance of developing trust within the community or with the individual. You know, you gave the example of a physician or someone coming in and telling a patient what to do, or this is what you need. That, that person's the educated one, that person knows through training. But if you don't develop a trusting relationship, it means nothing. Mm-hmm. And I think that's so important. And you could replicate that in larger community dynamics as well. So when we go into a community and say, this is what we need to do to address these needs, without ever involving the community in their own decision-making process towards, what they need, I think that's the detriment. And so I've seen through the years that it just takes time and to be with people and to let them get to know you. Now I'm talking community-based. I know a primary care appointment is not going to allow that much time to be able to get to know them, but I think we have to recognize what is the public perception of who we are in our communities and what we're known for, that people, that instills that trust. We've been talking about in Catholic healthcare in this country has gotten a bad rap on a variety of different things. So how do we elevate that notion of who we are in the community? And, for a long time, people knew us because the sisters ran the hospitals. There was, unlike me, there was a very public attire that you could see that sister in a habit, and there was a comfort level and trust that the sisters were taking care of this. But we don't have that anymore. Years ago, one of our sisters, she was a CEO at a hospital in Arkansas, and Arkansas is only 3% Catholic. And I don't know what it is today, but I remember her telling me the story that they were trying to do fundraising to build a new wing of the hospital. And, got a story from someone who said, a gentleman in the community, and said, I wouldn't give those Catholics a red cent. He said, but I'd give the sisters the shirt off my back. So they built such a trusting relationship in the community that people trusted what they did. And so now I think that's our challenge in Catholic healthcare, is how do we continue to build that trust in the community? And we only are able to do that by being in the communities. We can't stay inside the walls of the hospital or the clinic without being present to the people where they are and what their needs. So I think we've great strides in moving towards that. We see so much of it in a lot of our programs that we do in Catholic healthcare, and I like to believe this is where we have our roots. So we're particularly skilled at being able to do this type of work and developing community-based programs based on respect and trust that's being developed with those we serve.
That's one of the things I always talk to my team about as well, is that the legacy of the sisters. And I always find what was so amazing about, the Sisters of St. Francis of Philadelphia, who founded us so many years ago, it was a line that I heard in a video that was produced by Catholic Health Initiatives at one point, where it talked about, the sisters who were teachers became nurses, and the sisters who were nurses became teachers, and it all was dependent not upon like what their own personal desires were, but entirely by listening and responding to the communities that they were serving and following that call, and not saying, oh, I'm not trained for that, or that's not what my area of expertise, but saying, no, this is what is needed, and I'm going to rise to that challenge regardless of the difficulty. I always like to reflect upon that when when we're having a tough decision here or considering a change. If I'm uncomfortable with it, I'll let it sit. And when I'm walking my dog that night, I'll be reflecting upon all that the sisters accomplished. And then I'll be like, well, what am I scared of? It's time to go. We're being called. Let's do this. And it usually works out because we are, like I said, you're not listening. And if you listen not just to the community, but to all that's going around and the energies that are there, they lead you where we're supposed to be sometimes.
Yeah, and Phil, I also believe that I think there's a real learning in that. It to me, it tells us it's not about one aspect of care, but it's about whole person care. Mm-hmm. Because whether you're doing education or whether you're doing social work or whether you're providing, healthcare, it's about the person. And so we see this in many of the congregations, people who once served in education and they went into, healthcare, or they did this, they were still caring for the whole person, but doing it in a different way. So I think that's important for us to recognize as we look at, all the collaboration that's needed today to address the needs of communities. It's important that not one institution, whether it be healthcare or education or whoever, can do it on their own. It is a collaborative. And I think that's what happened in our early foundations. We saw that among the sisters, that I had a sister who said to me one time, this is when I was in congregational leadership, and she was working in a community in Mississippi, a very poor area, and she was doing housing. And she said, I'm ministered to care for the needs of these people, not just to do housing. So if something else comes up that is the need, whether it be education, that's where she's going to find herself being called and being able to respond to them. So she taught me a lot about, how to respond to needs of communities and not just looking at what do I have to give to this particular endeavor.
Mm-hmm. I think that leads into another question that I had for you around the interconnectedness, really, of all the systems. I think it's a perfect example. So for 15 years before I came here, I worked in HIV and AIDS, which is such a complex world with so many hot buttons. And one of the things that came out of it was, the first time I heard it at least, was this phrase that housing equals healthcare. Mm-hmm. And it was mainly around the concept of the housing opportunities for people with AIDS, now housing for people living with HIV, where we kind of recognized in that public health crisis that we couldn't treat someone's illness if we couldn't make sure they had a roof over their head and food in their kitchen, electricity on, so they could potentially at that time refrigerate the medications that we were working with them. And we had, actually real data then to support. So it was always like a gut instinct, I think, those of us in the activist field and more on the social service side. But then you started to see the data to show that if we could address that, and then you started to see it slowly expand, where I started reading articles back when I was still in HIV around emergency rooms in New York City who are now staffing their ERs with social workers who specialized in housing placement because they knew that recurring, ED visits were not necessarily associated with illness, but with homelessness. And needing to get out of the conditions or not knowing where to go and confusion. One of the things I think that challenges that have come out of us, I guess, to me, having a better understanding of health and holistic health is this idea that that healthcare can challenge it. And I always kind of joke because the answer is always like, well, you can add this assessment onto the 5-minute primary care visit. You can add this on to the primary care visit, to the point where like the person doesn't want to go to primary care because they don't want to get asked all these other questions. So when you look at now social determinants being a large buzzword, which maybe some people who are watching aren't overly familiar with, but in terms of housing, access to healthcare, food access, And all of those us now recognizing, driving the overall health of the people in our community, you know, our health systems positioned to be able to properly respond, not just temporarily. So I'm not talking about like a band-aid, but really to help. And I guess I keep saying I always say this to my team. It's just because I keep, you know, to me, like if we can solve the problems we're facing, that's the ideal. Like I'm not in this business to be in this doing the same thing 10 years from now. I'm in this business to solve what the immediate need is and then go on to the next challenge facing our community. So as health systems, are we, you know, positioned? How do we effectively maybe move ourselves to be able to properly and not just temporarily slightly address these social determinants, but really eradicate them in our communities? I'm not sure if that's the right word or the correct terming for solving them, but it's how I kind of view it. So how do we position ourselves, or are we already there?
I think that we're continuing improving our ability to do this. And I would say I've been in healthcare for over 25 years. And, you know, early on, you know, a lot of the work that we did out in the communities, it was to be of service, you know, to be the good neighbor in your community, to fund the marathon or to, you know, fund the walk, the bicycle, you know, thing for the kids or whatever it was. And we did these acts of kindness, more or less. And, you know, the schools, the daycares, churches looked to hospitals as, you know, the healthcare provider in the community that had a lot of money. And
Yeah.
so how do we get access to those money? You know, would they underwrite this sporting events for us? All those sorts of things. I think when we've recognized that how these other social conditions are impacting the health of individuals, and with the move from fee for service to value-based care, we say that we have to look at more intentionally figure out this problem, how we're going to address it and keep people healthy. So healthcare has evolved and more that these aren't random acts of kindness and good works that we're doing. They're very intentional. In our community benefit work, we do planning in terms of the needs of the community and what strategies will we develop in order to move the dial on addressing and improving their health needs. You know, healthcare has gotten involved in a lot of these programs. Your own health system, you know, years ago, I think, bought a hotel that was abandoned, no longer in use, and created respite care for people who are homeless, who had been hospitalized and have to be discharged with some sort of follow-up nursing care. Where are they going to go? Right? So we made concerted effort to try to figure out how are we going to solve this problem. And then it moves us one closer step to saying, now how are we going to solve the homeless problem? You know, how are we going to look at affordable housing? How are we going to work with other, you know, organizations like Mercy Housing? I had been on their board for a while and recognized the strong connection between, you know, healthcare and housing. We have probably in 5 cities across the United States right now, Catholic Charities and Catholic Healthcare are working together on housing initiatives and how to improve affordable housing for low-income families. We're seeing, I can give you case after case and example after example of how we're evolving and doing more of this, and not just as a random act, but we're seeing how this is core to the work that we must do. And even in your own organization, you're seeing it in terms of people who have at executive level responsibility over those types of activities and strategies that are now being folded into the strategic initiative of the entire organization. So we've come a great distance, and we still have work to go. You know, I think we're learning as we go. But I do believe, Phil, that it takes us back to our foundation. This is where Catholic healthcare started. So, you know, we're in the communities, we're serving the needs, we're recognizing we may not have all the answers, but how do we collaborate with other groups that are able to complement the services that we can bring to our communities? You know, your comment about going into the office and a physician's office and they start to assess for all sorts of things, that is the point of care. We're also seeing how do we put these health services into low-income housing units? How do you put, we used to, early years when I was working in inner city St. Louis, we were taking, healthcare services into churches that were providing food for people, and had an opportunity to do blood pressure screens, to do, all sorts of things at that point in time. So how do we bring healthcare out into the communities, not just look at how do we bring the community into the primary care sites?
Yeah, I think that's part of the challenge. And then that's what I think I started to see when you're in all these community meetings. We do a lot of outreach with behavioral health, and they're like, oh, well, we can add a depression screening. And I'm like, well, is that provider in that setting the best to have this conversation with the individual who is now somewhat vulnerable? And if they get a positive response isn't really the word I'm looking for. So they do a depression screening and it comes up that there is a significant risk or presence of depression in that person in front of them. Does that physician, are they the best person to know what to do? Or did we just now open something where we don't have an answer? I always used to joke, like we had a campaign locally, and it was a good idea because we wanted to raise awareness about behavioral health, and it was around depression. And it was all about trying to help people determine if they have an issue with depression. And I said, this is wonderful, but we have to solve the back end issue. Like if people all identify that they have depression, which is good, then how do we get them the care that they need rather than them just being more disappointed and depressed when they find out there's no service available? That we have to work in tandem of finding ways for people to know about their health and embrace their challenges and celebrations. But then we have to have the supports necessary as the systems and as the community providers to be able to offer the help. Otherwise, we potentially violate, I guess, the basic oath of healthcare, where we've done potentially more harm than we have done help by now pointing out and then saying, oh, well, I'm sorry, I can't do anything for you. It's an interesting dynamic where the easy thing is to do marketing, or that's the easy part. The hard part is that lift of how do we re-envision services? How do we change our operations to maximize? One of the things with COVID, I think it's forced all of us to kind of really look in the mirror a little bit about how we approach community response, how we approach our employees, because our employees were all at risk now. And one of the things that I've said is, I wish as a healthcare system, and we're being hammered as a healthcare system, every healthcare system is being hit very hard through this pandemic and doing wonderful work. So that's not a question, but I wish we could also, and I don't know how we would do it, look outward, because people are hurting so bad in the communities. And how do we make sure that they feel supported and embraced by those of us who are here in the health field to care for her, while we're also caring for ourselves and caring for the patients who are sick, which is, again, I asked that question before, like, are we asking too much? I probably just asked you too much of healthcare providers. But I think sometimes when we start to see crisis or panic within our ranks, we close ranks, when part of me wishes instead we would open. And then we can pull the community strength as well as our own internal strength to move forward instead of just supporting ourselves and supporting those we're caring for immediately. I don't know if that makes any sense at all, but random thoughts by Phil, right?
Yeah, no. There are lots of things that you said I want to kind of spin off of, but back to the point of the behavioral health and not having appropriate interventions for those who are, diagnosed with certain types of issues. And so you're right, you go in and diagnose, or you go in and then what if they don't have access? So it is all about access, so health providers can figure out, transportation issues, get them where they need to go, every good social worker can, work around the barriers to get people what they need. I think the other thing that we have to really focus on are the policy issues that need to be changed, that there's reimbursement on these. And you mentioned COVID. Pre-COVID, we saw the mental health crises in our country. The opioid crisis, the rates of suicide were increasing, rates of depression. And now with COVID, we're recognizing, as COVID has shined a light on so much, saying that we've got people who are isolating now. So the levels of depression, we're going to see more of this.
Mm-hmm.
We have got to make some, choices around payment reform in order to address these needs. So it's just not about, we don't have the providers, it's funding these things that are going to be so very important that I think, we're out in front of and trying to look at advocating for policies and legislation that will enable us to do that.
One of the interesting things that we were seeing, I think, before the pandemic really took hold, was within some of the political sphere. We were starting to see presidential debates within the Democratic primary. And for the first time that I can recall, and having, been somewhat a political follower, since my college days, but it was the first time that I could remember actually talking about health disparities on a presidential debate stage, and having not just like one candidate out there saying, no, we have to respond to our communities of color and we're doing them a disservice, which we have been. But having multiple candidates say, look, there's not just a problem, there's a fire, and we have real issues in terms of mortality rate and maternal care for African American women. How are we going to address that? Beyond that, then the health disparities that now you're starting to read more about, and how we have set up individuals to be disproportionately impacted by diseases that seem more commonplace or easily treatable in more Caucasian communities. I think the other day I even read an article, and I'm not sure if it is sourced right or not, because I didn't follow up beyond an initial scan of the article, around the gauges that we use to measure oxygen that would go on the fingertip, and that they actually read slightly differently in individuals with more pigment in their skin. So then you're creating, again, another, because we haven't had enough clinical trials and research on devices and medications in diverse populations, of potential disparity in the type of care that someone might receive simply because of how a device reads. How do we, as Catholic healthcare, as a healthcare industry as a whole, I guess, use our healing presence, our grounding in Catholic social teaching, and I think Pope Francis has been very spectacular on these issues, and our economic influence as large employers and, in essence, anchor institutions in our communities, to be able to kind of push and promote social justice, racial justice in our communities, and kind of begin that ball moving towards true reconciliation, where we're now a community of a whole that celebrates the uniqueness of all of us and embraces them, but assures that everybody has what we need to be successful.
Mm-hmm. Mm-hmm. Yeah, this is health disparity caused by, racism has been with us for a long time. This isn't something, that just came about in the past year. But I remember years ago when I served in healthcare boards talking with physicians who said, we need to begin to address this. You need to address this. But it wasn't on anybody's radar. I mean, we assume we're giving good quality care and everybody's getting the same good quality care, but we're recognizing that there are disparities. And what do we need to do about it? The clarion call has come again, I think, and I know for the Catholic Health Ministry, our board took a stance on this just at our last meeting, and looked at how do we begin to incorporate a strategic initiative on addressing racism as we look at addressing health disparity. And so I think there's got to be the will to act. And it has to become a strategic priority within the organizations if it's going to move the dial. And I believe healthcare is starting to look at, we've got to move on this now. This is blatantly obvious that racism is causing health inequities in our communities. And it's just not about poverty. People of color are going to have a high percentage of those who are living in low-income neighborhoods. So it's hand in glove, but it is about racism. So I think we have to start by saying, what can we do to help for our health ministries to be able to address this and have it as strategic priority? I also believe we have to look at internally, our own policies and procedures, and do an assessment of our own organization and see, where do we have areas where we are discriminating against people of color? We're not above the fray. we're human beings, and we're blind to it often. So I think it takes, again, an intentional looking at it to begin to elevate and address those issues. And then again, back to advocacy, what are the things that need to change that, basically create systems of oppression of people of color? And how do we address that? So I think we're on the cusp of the beginning of more activity around this area. And again, I keep going back to our roots, but I think that's what keeps us grounded. In our early history, we saw women religious. In the Civil War, they cared for both Union and Confederate. They didn't discriminate. And, during the time of segregation, the sisters I remember our sisters in Kansas telling the stories where they would, bring the African-American patients in at night into the convent to, care for them because they were not able to bring into the hospitals because of segregation. We always address the need, regardless of the color of a person's skin. And so again, the wake-up call COVID has brought to light again, how we as a country need to be able to address this and eradicate racism and institutional racism as well.
Mm-hmm. So if we looked into the future and tried to project a little bit, recognizing we want to be responsive to our community needs, where's the path taking us in the next couple of years with healthcare? I mean, we've gone through. You knew you were going to get this question, right? We've gone to the Supreme Court 2 or 3 times now with the Affordable Care Act. We're there kind of again. We had the Medicare for All discussion during the Democratic primary, and I'm sure it's going to be a major issue as we go into the general. As we start to kind of map out like a realistic projection of what might happen, or what we think would be best for communities so that we can have a responsive health system, what types of changes would you envision?
Well, I think a strong focus on accessibility and affordability. I mean, those are the 2 main things. And we heard that, with the passage of the ACA was very, very important to us. And how do we look at access? So it's not only coverage, but it's also affordable coverage. So people aren't making choices about, doing their copay or buying their medication or, paying their rent or paying their electric bill because they have a health bill that's coming in. So we've got to address those issues. What the service delivery will look like, I think telehealth is showing us a tremendous amount right now. And there had been, for a long time, we've had some organizations that have been doing some unique things with, EICUs. We have an ICU here in St. Louis that was caring for patients in Oklahoma and Kansas. And that's been in existence a good 15, 20 years. And as we move into seeing more access through telehealth into communities of need, we're going to be able to address this issue more and more in terms of making certain that we have coverage into our communities. I think, Phil, it's going to be interesting to see with the elections coming up. And of course, there has been so much in the past about Medicare for all. I think we have to not, ditch the ACA and start over again. We have to, build upon it and see where the challenges are in terms of making it more affordable and accessible and work off of that. I think if we were to scratch it and go back to, try to do something else, it's going to put us back 5 to 10 years and move us forward. I think we have to look at it in both ways, both around, the policy issues as well as what we need to do on the delivery end of it.
One final question before we wrap up, because I know you have other meetings as well. I think you touched a little bit on that in the answer right there. It's around access and availability, right? You create the access opportunity potentially with the Affordable Care Act or some addition to. But one of the concerns I think I've been seeing within healthcare as a whole is the idea that small rural hospitals are struggling and disappearing, which then makes it so that by giving access through creating an insurance-like product, then we still don't really have access because there's no providers for 200-300 miles from where you live. So I don't know if you have any thoughts on how we can collectively be supporting and trying to find solutions for that need. If the model shifts, I think telehealth is partly an answer, but not maybe entirely. If you had any thoughts on that and kind of impending and current crisis.
Yeah, I just saw some numbers a week or two ago around rural health because that is a major concern, particularly for Catholic healthcare. And what's interesting, there haven't been a decrease in numbers of rural hospitals that are sponsored by Catholic healthcare. We haven't left the community. So I want to make that public and say we're not abandoning the communities. There's been a lot of change in terms of for-profit hospitals that have left rural areas because my assumption is there's, a lack of profitability in those communities. There's definitely need. So first and foremost is say, yes, we have to look at funding, particularly for those, rural hospitals. That's very important to be able to ensure that they're going to be sustained through these crises. But I also know coupling that with what other types of resources are needed for that community. Hospitals were once the pivotal point of, just like schools and churches, those institutions were the pivotal places of the little communities in the towns. I grew up in a small town in Illinois. We didn't have a hospital. We had to go to the local community access healthcare. And if you were to take away our school, though, you'd hear us crying because that became the center point of the community. So what often happens is that, people hang on to those things, even though it's no longer necessary, but it's because of what it stood for. So how do we help some of these acute care facilities evolve into the type of health that's now necessary in this local community? Maybe they don't need acute care there. Maybe they have access, at another hospital 10, 15 miles away. What they need there, maybe a couple of, emergent beds, primary care, whatever the need are. So I think we have to reassess what are the demographics in those communities and figure out what's best going to meet the need for the patients. We assume acute care is still, the point healthcare provider in a community where it really we're focusing more to primary care and, having more community-based services instead of the acute care setting. So as we move to non-acute, we have to look at what is necessary within those communities.
Almost transitioning those facilities to like a unique community blend.
Yeah, I know we closed a hospital. This is now I say we, it's when I used to work within the Mercy system. We closed a hospital in Arkansas, and that, a facility then moved into another location. They built a new hospital. It was where the population growth had been. But the old facility became a social service arm. So it was a point to go in and every, you can get rent assistance, you could get utility assistance, you could get, had a food bank there. There were all sorts of things that you could sign up for Medicaid there. It was a social service community center for the neighborhoods around that hospital that was very important because they no longer needed to have acute care in that, local community.
Well, Sister Mary, thank you so much for taking some time to join us. I really enjoyed our conversation and look forward to hearing more from you.
Thank you, Phil. I appreciate it.
Thanks.